Hey everyone, Ensign Flood here. So today we're going to talk about hyperthyroidism, primarily a little bit about hypothyroidism. So let's make this short and sweet. So I just want to recap a little bit about developmental biology because this is actually an area that you might see tested a few times on step one. So here in the center we have basically the thyroid gland in purple, and then these dots are the parathyroid gland. I just want to talk about how they come from two discrete processes that you might see and some of the clinical correlates to that. So let's start over here on the right side with this big face. So this is going to be the thyroid's development. So here we have the tongue, and right underneath the tongue, this little purple dot is what's called the foramen cecum. And basically what's going to happen is the foramen cecum is going to become this thyroglossal kind of progenitor and migrate down towards where the thyroid will end up. But if it gets stuck en route, then you can get a thyroglossal cyst, which you might hear a little bit more about in ENT or surgery. So otherwise, the thyroid will continue migrating as a whole down to its final origin. So you can kind of see where that is right next to the parathyroid glands. Okay, so the parathyroid glands come from, like I said, a different process. And this is basically relating to this thing called the pharyngeal arches. So just remember, you have the nasopharynx, the oropharynx, and the hypothyroid kind of all back here. So this is sort of this primitive tissue that will organize itself into a lot of different structures. But what's really tested a lot on step one is this relationship between the third and the fourth pharyngeal arch, because it's a little bit confusing. I put the thymus here in for just kind of a little bit of orientation, even though it's going to be way down by the heart, but we'll talk about why that's relevant here in a second. So basically what happens is the third pharyngeal arch will travel down pretty far and become the inferior parathyroid gland, whereas the fourth pharyngeal arch will become the superior parathyroid glands. And so why I bring this up is you might hear about this in pediatrics where you have something called DeGeorge syndrome. So basically this is a malformation of all these pharyngeal arches, and these children get a lot of facial deformities. They get hypoparathyroidism and they get hypothymic, so a lot of immunosuppression there. So I don't want to digress too much, but I just wanted to say where everything comes from because it all does have clinical correlates. So going into hypothyroidism and hyperthyroidism, basically the reasons to get a thyroid stimulating hormone test. This has probably been hashed over a lot, but just to kind of recap, they're polar opposites. So hyperthyroidism, you're going to have a lot of heat intolerance, weight loss, be sweaty, have a lot of diarrhea, be hyperreflexic, tachycardic, etc. And hypothyroidism, you're going to be cold all the time, be gaining weight, be constipated, have low reflexes and bradycardia. So pretty straightforward there. Now just a couple of notes on hypothyroidism before we move on. The most common type of hypothyroidism is Hashimoto's, which is associated with the anti-TPO antibodies. You can also have this thing called subclinical hypothyroidism, where you have a high thyroid stimulating hormone, but a normal T3, T4 level. And so you don't really have to treat it unless it's symptomatic or it's like Hashimoto's essentially because it has those antibodies against TPO. Another thing you might hear about is a syndrome that's associated with malignancy called the sick euthyroid syndrome. So this is basically where you have low everything, low TSH, low T3 and T4, but you have this unusual thing called a R or reverse T3. So when you see reverse, that's going to be basically a cue for potential malignancy with this sick euthyroid. Just one more thing, you might have myxedema coma, so that's basically an extreme case of Hashimoto's where people go comatose essentially. And so before we get there, hopefully we treat these patients early on with levothyroxine, so that should be pretty straightforward. Okay, hyperparathyroidism is a little bit more involved, so let's dig into that. The good news is that the treatment is actually pretty much the same with one caveat that I can think of. Basically, you want to have something like PTU or methimazole. I just put here in notes that Women who are in their first trimester should go on PTU and then switch over to methimazole on their second and third trimesters. Alternatively, people can get radioablation. Now, another treatment might be just symptomatic. Like I said, a lot of these people who have hyperthyroidism are tachycardic, so you might want to treat them with a beta blocker, particularly subacute or de Quervain's thyroiditis, which we'll get into here in a second. So, working these people up. Typically with hyperthyroidism, you would expect a low TSH and high levels of T3, T4 that are basically feeding back a negative inhibition signal. But if you don't have that, you might want to look for a secondary cause, like an adenoma that's secreting these levels of TSH, so basically everything is high. Otherwise, physical exam does a lot. So right off the bat, does this person simply look like they have Graves' disease? And if they do, they most likely have Graves. You can follow this up by doing what's called a radioactive iodine uptake test, so an RAIU, sorry about that. And this basically comes back with 3 potential findings. So the first of which is just iodine everywhere. Basically, the thyroid would look black in this screen, so it's diffuse. That's Graves. If it looks nodular, you can have 2 choices. Basically, toxic adenoma, which is a single nodule, or multi-nodular, which is multiple nodules. And just as an aside, sometimes you can actually feel the single or multiple nodules on physical exam, so don't overlook that. Finally, the RAIU can look really low. And so in this case, we want to look at the thyroglobulin. Now, the thyroglobulin is normally stored in these follicles, but when the thyroid becomes injured, such as in the case of an infection, those globulins are released into serum so they could be detected. And so if they're not detected, we might be thinking that this person is just giving themselves too much, basically levothyroxine or some sort of exogenous source. Otherwise, if it's high, then we're thinking damage to the thyroid, and there's a couple of different choices. Either 1, it's not painful and it's just called silent thyroiditis, or 2, it is painful, and this is what we were talking about with subacute or de Quervain's thyroiditis. And so just as an aside here, basically what happens is you have this illness that basically causes injury and releases all of the T3 and T4 out into circulation, and then it clears up. But in the meantime, the thyroid has to recover, and so you might have a rebound hypothyroidism. So keep that in mind with these subacute thyroiditis. So to kind of recap, we have the foramen cecum that lives under the tongue. It descends all the way down and becomes the thyroid. Otherwise, you get that thyroglossal cyst. We talked about how there's those pharyngeal arches, where the 4th pharyngeal arch will become the inferior parathyroid gland, and the 3rd pharyngeal arch will become the superior. Oh, see, I got it mixed up. It's superior parathyroid comes from the 4th, and inferior comes from the 3rd. Sorry about that. Secondly, obviously know your signs and symptoms of hyper versus hypothyroidism. The best first test, no matter what, is a TSH, and also T3 and 4 are useful. If you're unsure from there, use your RAIU, and if you're still unsure, look for the thyroglobulins as a sign of that injury, and pay close attention to the physical signs, because nodules or diffuse kind of goiter will point you to different things. One quick bonus while we still have time, I just want to mention in other modules you might see that high estrogen induces this thing called the T4 binding globin, so TBG. And so basically what that does is they bind all of these free T4s. And so if people have hypothyroidism and are taking levothyroxine, they might have to increase their dose if they are pregnant, or actually if they're cirrhotic, because cirrhosis is a hyperestrogenic state. All right, guys, study hard and great job.